Hello, this is chapter 7, where we will talk about the femur and the pelvic girdle. And today we will talk about the intro portion of the chapter and the anatomy, and then we will discuss the views done for a femur. All right, so chapter 7, if we start off looking at the hip and the proximal femur, because we've just come through, we've covered so far the foot, the ankle, the calcaneus, the tib fib, the knee, and now we're actually looking at another long bone, which is the femur. And we'll also look at hip and pelvis in this chapter. When we look at the proximal femur, this is actually found on page 264. And you can see you have the femoral head on both of these. This is a posterior view of the femur. This is an anterior view. So the femoral head actually sits in the acetabulum of the pelvis. So if we go back for a second and look right in here, that little cup-shaped depression in the pelvis is called the acetabulum, and that's where the head of the femur sits to actually form the hip joint. As far as anatomy, we have the head of the femur, we have the femoral neck, we have the greater trochanter, and we have a lesser trochanter. And the head of the femur is a smooth, round, articular surface that I said articulates with the acetabulum. And then we have also the greater and lesser trochanter. The greater trochanter is found superiorly to the lesser and laterally. So if you touch or palpate the outside of your thigh up near where your hip bone is, it's a palpable bony landmark. All right, and the greater trochanter usually correlates with the level of the pubic symphysis. So if you remember when we discussed abdomen, we said that instead of palpating the patient's pubic symphysis, it is possible to palpate the greater trochanter and know that that lies in line with the pubic symphysis. So it's a good cheat as a palpable bony landmark. The lesser trochanter is actually a smaller eminence that projects medially and more posteriorly, because this is the posterior view, from the junction of the neck and the shaft of the femur. Okay, and then in between the two, between the greater and the lesser, it's much easier to see from the back side. You can see this intertrochanteric crest that connects the two of them. It's just a really thick ridge of bone called the intertrochanteric crest. And then we have the body or the shaft of the femur. When we look at the angles of the proximal femur, you can see that the first one that they show you is that there is a 15 to 20 degree angle when the patient is upright. When the patient is standing up straight, notice that the femur does not come straight up and down. It actually angles outward, anywhere from 5 to 15 degrees. All right, so in the book it tells you that an average adult, the plane of the femur is about 10 degrees from vertical. And it says it's closer to 15 on somebody with a wide pelvis, shorter limbs, yet it's only about 5 degrees on a long-legged person. So 5 to 15 degrees, depending on the patient's body habitus. And it says it affects the positioning in the central ray on a lateral knee. And we've talked about that before as far as having to angle on the lateral knee 5 to 7 degrees cephalic so that we could superimpose the condyles. And then they reference that the neck and the head of the femur is the 15 to 20 degree anterior angle of the head and neck in relation to the body. So if you look at the head of the femur and the neck of the femur in relation to the body, it's anywhere from a 15 to 20 degree angle, anterior angle. And the reason that angle is important is because the femur and the lower leg end up having to be rotated 15 to 20 degrees internally in order to place the femoral neck parallel to the IR for a true AP of the proximal femur. So because of this degree of angulation between the femoral head and the body of the femur, you actually end up having to internally rotate the patient's leg 15 to 20 degrees to make the femoral neck parallel to the IR. So they tell you that from the neck to the shaft is about 125 degrees. The longitudinal angle is give or take 10 degrees, and the anterior angle is 15 to 20 degrees. When we look at internal versus external rotation, this is actually found on page 261. Right, so with looking at the right hip and leg, notice that this is internally rotated, like the foot and the leg is rotating medially or towards the midline of the patient. And then external rotation is where the leg is actually pointing outward. So when you internally rotate, you tend to demonstrate the greater trochanter, and notice how you cannot see the lesser trochanter. So what you're trying to do when you internally rotate, if you were doing the AP, you want the greater trochanter to be visible. You're trying to place the femoral neck parallel to the IR so that the lesser trochanter is not visible. But notice when the leg goes the opposite way and it's externally rotated, you tend to diminish the greater trochanter, but the lesser becomes much more prominent. Now again, like everything we've talked about so far, why does that matter? It matters because when you're actually looking at your radiograph and trying to decide if it's anatomically correct, if it was positioned correctly, there are certain key things we look for, and one of them on the femur or the hip is that we look at the greater trochanter versus the lesser trochanter. And if you're an AP of the proximal femur or an AP hip, you don't want to see the lesser trochanter if at all possible, and that means you have the correct degree of rotation internally. Now, why do we mention external? It's not so much that we do this on purpose, but sometimes when a patient has a fracture, what will happen is that their leg will actually flop outside, or it just tends to lay shorter than the other leg, and the foot tends to flop out. So that's just a good indication that most likely there is a fracture to the femoral head or neck. So it's just something that we need to look for. If we look at some of the positions, these are over on page 272. If we look at the patient, they're showing you how their feet are. They're in anatomic position, meaning that there's no internal rotation. Their feet are just straight. Long axis of the feet are vertical. So the femoral necks are going to appear foreshortened, and the lesser trochanters are partially visible. You can see they're pointed out on here. Greater trochanters would be out here. Notice that this is a little bit dark, but the greater trochanters are going to be out here. Again, that's a little overexposed, but this right here that they're pointing to is the lesser trochanters. So right where these arrows are pointing in towards the lesser trochanters. And I said that if we were doing an AP pelvis, or I'm so sorry, AP proximal femur or an AP of the hip, this is not what we want to see. So that would not have been positioned correctly. The next, if we look at the feet in a true AP, that is where there's 15 to 20 degree medial rotation or internal rotation. Right, so both feet are internally rotated 15 to 20 degrees. And notice that the lesser trochanters are much less visible on this, and the greater trochanters, which are right here, and right here. Those are much more visible. These, however, are much less visible on here. So that's actually a really good AP of either the proximal femur or the hip, because you're trying to increase visibility of the greater trochanter and decrease the visibility on the lesser trochanter. When we do external rotation or a relaxed position, a lot of times this is how patients, when they lay on the table, nobody tends to lay with their feet. I mean, when most people lay down, they're not going to lay like this. It's just not a natural position. This is a much more natural position with the feet flopped out, externally rotated, or just relaxed. And with this, the femoral necks are severely foreshortened, and you tend to really be able to visualize the lesser trochanters, and they point them out very well here. Notice that the greater trochanters are not as prominent as they were in this last picture. Much more prominent on this image versus this image. The lesser are much more prominent on this. So this is external rotation. And then the last one, this is called asymmetric rotation. And this is typically what happens when a patient has a hip fracture. Again, it's not something that they intend to do, but when there is a fracture either to the femoral neck or to the femoral head, a lot of times what will happen is the affected limb will, the foot especially, will flop out. Sometimes it'll be all the way down to the table. And usually what will happen is the affected leg will appear shorter than the other leg. All right, so be mindful of that. If you ever get a patient that comes in, you look, you know, they're bringing them in on the stretcher and this is what you see when they come in, be very, very mindful that there's likely a left hip fracture on this patient. And then they show you on here, there almost is no femoral neck. There is no femoral neck on here because of the way the fracture is. That shaft of that femur has been shoved up into the femoral head. So again, this is how the patient would present. So you want to be very mindful and careful not to manipulate their leg to cause further injury. Because if you think about it, we don't ever want to manipulate the patient if we suspect a fracture. We want one image in the position they're in to see what we're dealing with before we do anything. Now, why would that matter so much with the hip and the proximal femur? Because you actually have the femoral artery that runs along there, and if you were to accidentally manipulate the patient or cause them to manipulate their leg in such a way while you were trying to position them, like let's say this is how the patient presented and you decide that they need to internally rotate that leg, that this is unacceptable, and you rotate that leg, it is possible that you would sever the femoral artery. So anytime, you always want to evaluate your patient as to how they present when they first come in, and you want to be extra mindful to not cause them any unnecessary harm. As far as shielding, typically when we do femur and hip and pelvis, we can shield on a male patient. Okay, it can be used on all male patients, typically because we have these small flat contact shields. Remember that the male gonads do fall below the pelvis. We're talking about shielding the testicles, so they don't, the testicles where they lie anatomically, they don't obscure any anatomy of the femur, the pelvis, or the hip. Okay. Now, as far as the female patient, they do show you on page 273 that on a female patient, this is telling you for abdominal and pelvic shield, if you were just doing, if you were doing the proximal femur to just get the hip joint, and they specifically said they only needed the hip joint, then yes, you could shield like this. This is designed to come down and cover the ovaries, and then they're attempting to shield the abdomen as well. They're going to show you this little ovarian shield for hips and proximal femur. Okay. This is also something, depending on the exam that they order, that you could use. But honestly, on most female patients, gonadal shielding is not possible. If they order a pelvis, it's not possible. Typically, if they order a hip or a femur, you can shield when you're doing the distal images, but typically not on the proximal. Sometimes we'll lay the shield, like if we're doing right hip, you can lay the shield so that it covers some of the left side, but you want to be careful that you're not obscuring anatomy, because having to repeat because you got the shield in the way is probably more significant than not shielding the first time and not obscuring anatomy. Okay, so typically we do not use the shield on females when the central ray area of interest is up here. All right. And again, that can be found on page 273. Okay, now we're going to go into the positioning. Now, I recognize that I did not put an extra slide in here to tell you that what the routine positions are. Now, this is for the femur. So when we do a femur, there's actually 4 images that we do. We do an AP of the distal femur, an AP of the proximal femur, a lateral of the proximal femur, and a lateral of the distal femur. So it's pretty much 2 APs and 2 laterals. Now, why 2? Remember that we're talking about imaging a long bone. And when we look at the femur, we actually, this long bone, remember that when you image a long bone, you need both joints. So we're going to need knee joint and hip. And because of the size of an adult femur, it is not likely that we would get all of that on one 14x17. So typically 2 separate APs and 2 separate laterals. Now, if you had a smaller pediatric patient or maybe a small, very small adult that it would fit, then you might be able to do that. But typically, if that's the case, they're probably not ordering a femur on that patient. Okay, now the technique for the femur is on all of the views that we're going to discuss except one trauma view. The technique is 80 kVp at 12.5 mass. And this is going to be an AP of the mid and distal femur. So this is actually found on page 276. Notice that we're on a 14x17, which is found in the bucky. We're going to have the long axis of the part along the long axis of the IR. So you're really only going to collimate from side to side on this particular image. Nothing from top to bottom. You're going to want the entire 16 or 17 inches open from top to bottom. Your patient will lie on their back on the table, ideally with the affected leg more towards the middle or the center of the table. And then we're going to have to rotate their leg internally approximately 5 degrees in order to get a true AP, just like when we did an AE knee. So this is not the 15 to 20 that we talked about with the proximal femur. We'll talk about that when we do the next image. This one is actually only 5 degrees, just like when we do the AP knee. Central ray is pretty much perpendicular to your mid light field. So however much you're capturing, because we have to capture the knee joint and as much of the rest of the femur as we can. So we're literally just splitting that light field in half, and that's where your central ray is. Okay, so if you have 16 or 17 inches, you're going halfway in between. Notice it says central ray to the midpoint of the image receptor. So you want to make sure you include the knee joint and get as much of the distal femur as you can. And then as far as the image, okay, AP distal femur, this is a left. You have to include the knee joint, like we said. There should be no rotation, so this should be a true AP, which it's close. It's not exactly spot on. The leg should have been internally rotated. Maybe didn't rotate the 5 degrees, because you can kind of see how the patella is more to the right. You can see right in here that that is not exactly straight up and down. So maybe they forgot to do the 5-degree medial rotation on that. Okay, so you've got knee joint, and then you've got about halfway up the femur, which is fine. Then we get an AP of the proximal portion of the femur, and this is found on page 285. So we're going from page 276 all the way to page 285, and this is called an AP of the proximal femur. All right. Now we have the same size IR, likely because it's digital. In the book, it tells you to collimate approximately to a 10 by 12. But recognize that you have to make sure that you overlap your two images. So you can see this comes, the shield is at the top there, but if this is her knee, they've got a good portion of that distal femur. So that when they do the AP, you just have to make sure that where this line is, that you have a little bit of overlap. Kind of like when we talk about abdomen and the fact that you have to have overlap. So if your one IR was like that and your other IR came up like this, then all this area in here would be overlap, which is what you're looking for. You want the radiologist to be able to prove that you've gotten everything on that image and not missed any anatomy. Now at this point, with the proximal femur, we have to internally rotate the leg 15 to 20 degrees. Remember we said we're trying to rotate that leg in so that the femoral neck becomes parallel to the IR. So this is where that 15 to 20 degree rotation comes in. So we internally rotate the leg 15 to 20 degrees medial, and this makes the femoral necks parallel to the IR and gives us a true AP of the proximal femur. The central ray is to the femoral neck, and the femoral neck is found 1 to 2 inches medial and 3 to 4 inches distal to the ACES. I guess I did not put that slide in here. I can tell you that if we look back on page, you can look with me even though it's not in here. I will go back at some point and add the image that they talk about with reference to this. It's on page 271. Again, I don't have the slide, but if you look on page 271, that top image, 7.22, shows you that if you look on the right-hand side, method 2, it shows you that from ACES, you go 1 to 2 inches medial and 3 to 4 inches down from ACES. And notice it's got a letter N, and that means that you're at the femoral neck. Okay, so you're going to palpate the patient's ACES. I am on the wrong slide. So sorry. Hang on. Okay, so you're going to palpate the patient's ACES, which it's hard to tell with the shield. Let's just it's so hard to do with not being three-dimensional. But what they're saying is you find ACES. Let me make it with a cap A. So let's say ACES is here because it tends to sit a little bit, right? So there's ACES. You're going to go 1 to 2 inches in from ACES, and then 3 to 4 inches down from ACES. Okay, so 1 to 2 medial, and then 3 to 4 distal. And they tell you that if you do that, that should place you right at the femoral neck. Okay, so central ray is perpendicular to the femoral neck, which is found 1 to 2 inches medial from ACES, 3 to 4 down from ACES. So you want to be perpendicular to the neck of the femur, which you have to internally rotate the leg so that it's a true AP, and literally perpendicular right to that femoral neck. Okay, so you can see central ray. Now, I'll be honest, when we do this, we absolutely do not have that kind of shielding on there, typically because you're probably going to obscure something. So usually what we do is just don't have a shield. You just collimate 10 by 12 lengthwise would be acceptable. And you center at the mid-femoral neck, perpendicular. And then when we look at the image, you need the proximal 1/3 of the femur, so you want to make sure you have overlap. You can see the hip joint and the acetabulum, so that's the femoral head. Acetabulum is right here where the cup, it's kind of the cup that holds the head of the femur. It's like a ball and socket, so the head of the femur is your ball, and the acetabulum is a socket. Notice it says the lesser trochanter is either not visible or only slightly visible, and it is absolutely not visible. It is right here. Right here, you can kind of make the outline of it. But they've done a really good job internally rotating the leg so that you can visualize greater trochanter, but not lesser. If they had a prosthetic, like a fake hip, if you look on page 285, that bottom image, 7.67, actually has a prosthetic hip. If there is a prosthetic hip, you have to image the entire prosthesis, if possible, in one image. You can't just miss a little bit of the bottom and go, oh, I got another picture. You have to get the entire prosthetic in one image. And as far as exposure factors, these are really good. Okay, so that's an AP of the proximal femur. So far we've done an AP of the distal, AP of the proximal. And now that we're up, remember we're up in this aspect of the patient, so we're proximal, our next image is going to be a lateral of the proximal femur. And this is found on page 287. And this is called either a unilateral, meaning one. Unilateral means one. If it was both, it would be bilateral. So this is a unilateral frog leg position, but typically we refer to this as the modified Cleaves method. Okay, so again on page 287, and this is done if it's a non-traumatic hip, meaning if you suspected a fracture, you absolutely would not do this view. Okay, so you can see there's two different images. One, the patient's leg is not as significantly dropped out. This is probably only abducted about 20 to 30 degrees. And then if you look at this picture down here, the leg is completely flopped out, more like a 45-degree from vertical on this one. Most patients are not going to be able to do this. This is typically what we do. We just have them drop their leg out as best they can. Okay. Notice it says that it's 45 from vertical to demonstrate the femoral head and acetabulum, but it's 90 degrees. I'm so sorry, 90 degrees from vertical to demonstrate the femoral head and acetabulum. But so this is 45 from vertical, meaning if it was completely straight up and down, from here to here is about 45 degrees. Whereas if it was vertical here and now you're completely flat, that would be a 90 degree. 90 degrees from vertical. I'm is not wanting to cooperate. So if you look on page 287, it says that a 45 from vertical is for a general femur region. And if you were trying to look at specifically the femoral head and acetabulum, then you would go 90 from vertical. But if you suspected a fracture, you're never going to do this inset picture. We typically always do this top one just for generalized purposes of a non-traumatic hip. Okay. Modified cleaves, the central ray is perpendicular to the mid-femoral neck. So you're again 1 to 2 inches in from ACES, 3 to 4 down. All right, so if ACES was right, ACES is right in here, you're 1 to 2 medial, 3 to 4 distal, which puts you right here, mid-femoral neck, and the central ray is perpendicular. I'll tell you a cheat that we typically use on the AP and on the lateral of the proximal. It's just a cheat. It is not going to be found on the registry, but typically what I usually do is have the patient bend their knee, and where their leg creases, that's a really good, like you put your hand crease of their leg, and that's just a really good cheat to find the middle. All right, so when they bend their leg up, when she bends her leg and it creases right here, you tend to go right in the center of the crease, both center from this way and center this way. Okay, that tends to put you right about the femoral neck. But again, that's not going to be on the registry. The registry is going to say that the central ray is perpendicular to the mid-femoral neck, which is found 1 to 2 inches medial from ACES, 3 to 4 inches distal. I'm just telling you that if you bend their leg, typically if you center in the middle of the crease, that's usually a pretty good cheat. Now, radiographically, this modified cleaves, when we look at it, you want to make sure you see the entire femoral head, neck, and trochanters. The femoral head and neck should be in profile because it's a lateral. Okay, and then you want optimal exposure factors, and this was done for a 45 degrees from vertical abduction. All right, so this, sorry, I went the wrong way. This is actually, this one right here is what they did, 45 degrees from vertical, and that would give you this image right here, which puts the femoral head, neck, and trochanters in the middle of the IR. And then you get a profile view of the femoral head and neck. Right? Really good image as well on that. Good exposure factors. So that is a unilateral frog leg or a modified cleaves. So that's our third view. So we did AP distal, AP proximal, lateral of the proximal, and now we're going to do a lateral of the distal leg. This is found on page 277. So if you look on page 277, notice the patient has rolled onto their affected side, but again, their unaffected leg remains behind them. You're going to have the image receptor as far as collimation. It's going to open back up because on the AP distal, it was open like this. AP proximal in the modified cleaves, probably your collimation is going to be more like a 10 by 12 lengthwise. So notice when we look at this image, you can tell that is not open to a 14 by 17, and neither is this image here. Okay, those are both collimated, but the AP distal is pretty much open all the way. And then when we do the lateral distal, it's going to be opened back up. Okay, so you want a true lateral. The knee is typically flexed 45 degrees. They're laying on their affected side. Unaffected leg remains behind them. And you want to make sure you include the knee joint on this. And you also want to make sure that up here that there's overlap from your lateral of the proximal femur. Central ray again, midway between your light field. Okay, so it's perpendicular to the midpoint of the IR. And when that image comes out, you will have the proximal femur will not be superimposed. The leg should be in a true lateral position. And then you have ideal optimal exposure factors. That's a mid and proximal. I'm so sorry. That is not what we want. That is, okay. So this is what we're doing. Lateral of the mid and distal femur. And this is actually what it would look like, because remember, we have to include the knee joint on that. So in this image right here, you can see that you've got the knee joint in there and you've got the distal portion of the femur. And this is what you're going to end up looking like. So you have the distal 2/3 of the femur, including the knee joint. The knee joint does not appear open, which is acceptable. And the condyles are not superimposed because remember, it's a perpendicular central ray. So there's no way you're going to open that joint space, not to mention it's in the middle of the femur. Remember, in order to open the joint space, it has to be angled 5 to 7 degrees cephalic. So it is not surprising that the knee joint is actually, the condyles are not superimposed. Right? And that is a lateral of the distal. And again, that's on page 277. Now, if we have a trauma femur, then the images that we do are an AP of the proximal femur, an AP of the distal femur, a cross-table lateral of the distal, and a cross-table lateral of the proximal. Okay. So when we do AP of the mid and distal, again, typically this is what it, how we start out with AP distal. You usually start at the bottom. I know this slide says AP proximal, AP distal, but truly you would do it the AP distal first. So you would do this one first, this one second, and most likely this cross table distal third, and then the proximal, which is a different view, fourth. All right. When I put up your PowerPoint slide, I will try and put them in order for you so that that isn't as confusing. So I'll reorder those before I post your PowerPoint. Okay, so we do, first is AP of the mid and distal femur. Remember, this is just like we did on page 276. So we immediately rotate the leg 5 degrees to get it true AP. Central ray is to the midpoint of the IR. So 5-degree rotation, midpoint of the IR, AP, mid, and distal. And then that's what our image should look like. We get the knee joint on there. And then we do an AP of the proximal. Okay, so exactly like we did on 276. And then we do an AP of the proximal, which is back to this, and that is on page 285. So you do the proximal portion. Remember, we said that shielding is not likely there. You find ACES and go 1 to 2 inches medial, and then 3 to 4 inches down. And we get this image right here. And then we would probably go to a lateral of the distal femur. And remember, it's a cross-table lateral. So what we end up doing is placing the IR on the opposite side of the patient and doing a horizontal beam. So this is a trauma lateral or across table lateral of the mid and distal femur. Okay, so the beam is coming through horizontally, capturing it on the IR. And then your image on that one, as it's shot cross table, would capture the distal portion of the femur, including the knee joint. So this is the lateral of the mid and distal femur. That's your third image, and that is actually on page 277. Figure 7.4. They actually show you the image reception and placement, and they talk about the fact that it may or may not have a grid. And then the last image we do, the lateral of the proximal, is actually found on page 286, and this is called a Danielius Miller, or an axiolateral infrasuperior. Okay, again, this is found on page 286, the Danielius Miller method. And notice it says your central ray is perpendicular to the mid-femoral neck. All right, the technique on this, you are not misunderstanding me. It is significant. It is 90 kVp at 40 mass. 90 kVp at 40 mass for this Danielius Miller. Now, this is common. We do these a lot for trauma and for post-surgery patients. So there's no rotation of the leg. You can do this on a stretcher. You can do it on the patient's bed. Do it on the x-ray table. But pretty much what happens is you put your image receptor in the crease above the iliac crest. You can see the end of the IR is above the iliac crest. And you make it parallel to the femoral neck. So you can see right here they're showing you, you want it to run in line with the femoral neck. So if the femoral neck is right here, then you want your IR to be parallel to that. Make sure that there's no rotation of the pelvis, and how you actually check that is you palpate both ACEs and make sure that the distance from the ACEs to the tabletop is equal. Make sure your hands are level with each other when you have your hands on their ACEs. And the last thing is you flex and elevate the unaffected leg. Notice this is the affected leg. This is the unaffected leg. So they have her flexing that unaffected leg and trying to bend it out of the way. Okay, the thigh becomes near vertical, and you want to move it outside the collimated field. Now, they warn you in the book not to place the patient's unaffected leg on the collimator, or not to place it on anything where it could be damaged. We have in the lab, I don't know if you ever saw, there's a thing that looks like a little goalpost up on top of the cabinet, and that is actually designed to hold the unaffected leg up out of the way. Okay, it's a little wooden apparatus. Many of the sites have it, and it just holds the unaffected leg out of the way. So this is called your Danielius Miller, or your cross-table lateral of the proximal femur. Just another image for what it ends up looking like. Again, notice they have the patient's foot on the tubing, not ideal. You also don't want to have the patient rest their foot on the collimator box or on any of the equipment. This is not ideal. There should be some kind of the little holder underneath here. That would be better. It usually holds the bottom portion of the leg, and then it comes down and rests on the table. Okay, that would be better if they had something like that, so that the patient's leg was not on that. Basically, that's plastic covering cables that allows it to move around the room, because that's a ceiling mounted tube. So they're just cables covering those so that it can move a little bit better. Notice the IR is in the crease above the iliac crest. Now, I don't know about you. I don't necessarily find this to be parallel to the femoral neck, I would assume the femoral neck probably is like this. So I would argue this IR here is fine, but it needs to come more in line like that. So this should be brought over this way. It typically doesn't stick straight out like that. Typically comes points more down like that because you want these two parallel to each other. Hopefully that makes sense. As far as the evaluation criteria on the axiolateral or on the Denalius-Miller image, right? Now this was done, this could have been done after surgery when they put in this prosthetic, but you need to visualize the entire femoral head, neck, and acetabulum. So here's the prosthetic femoral head, prosthetic neck, and the acetabulum. This is actually the acetabulum here, the cup-shaped thing, and then the femoral head. Let me try and outline that. So prosthetic acetabulum is this right here. And then the femoral head right there. And then you have the neck portion of the femur right there. Okay? So you have to capture all of that. You want no visible grid lines in there. And the central ray on this is, the central ray on the Denalius-Miller is actually perpendicular to the femoral neck. Okay, so when you look back at this, all they're doing is coming literally right into the femoral neck, which is just below the point where the femur looks like, or the thigh kind of joins the body. It's not very nice to say, but I can tell you that typically the Denalius-Miller is often called a crotch shot. Again, not very nice, I understand that, but if you think about it, you're pretty much shooting directly into the patient's crotch, which gives you a cross-table lateral of the proximal portion of the hip. So again, you're not really going right into the crotch, because obviously, think about that, you're talking about the point of pubic symphysis, which is not what you're trying to image. You're trying to image the femur. So it's just off center from that. So you're perpendicular to the femoral neck. And the technique again is 90 kVp at 40 mass. Right? And this is what your image would look like. And again, this is when we said before about having to capture the entire prosthesis in one image. This is what I'm talking about. If you actually took an image and you missed a portion, you cannot just get another image over here and say, oh, there's the rest of it. That wouldn't work. You'd have to capture the entire prosthesis in your original image. So it means you would have to go back and re-expose the patient in order to capture that. Okay, so just one more time to wrap up. A femur is 4 views, 2 AP, 2 laterals. If it's a trauma femur, it's still 2 APs and still 2 laterals, but your laterals then become cross-table laterals. All right, so hopefully you guys printed out this PowerPoint, took notes on there. If you have any questions, make sure to write them down, and we will discuss during our next live session. I hope you have a good day.